All right, so as Tom said, I'm going to sort of give an overview of HIPAA, the HIPAA privacy rule and research, kind of following on the ANPRM discussion. HIPAA imposes a number of requirements on research. It was an open question, I think, at the outset as to whether research was going to be subsumed under HIPAA, but it is, and long since. And so, so here we are. And a lot of you are probably aware that there was a major, well, first statute that changed, the high-tech statute that changed many of the HIPAA rules, and that caused the Department of Health and Human Services and the Office for Civil Rights within HHS, which is responsible for HIPAA, to issue a new rulemaking. There was a proposed rulemaking a long time ago, and there was a final rule issued last January, so we're a year in. And research was not really a change in the statute, but HHS, I think, had listened to the concerns of many of you over the years, a lot of work that IOM had done on evaluating the challenges that HIPAA was posing for research. And so they did some important things, and I think I'm going to walk through those changes, but I think a lot of the question is, how far did it get us? Did it get us far enough, and what more still remains to be done in order to ensure that, you know, that HIPAA is both protecting privacy but not unduly impeding research, and how are those balances struck? So I have a lot of acronyms in here, but I'll try to spell them out. Under HIPAA, the rules, you can use protected health information, which is PHI, that's the information that's governed by HIPAA, for research in certain circumstances. And this is the pre-January 2013 set of rules, and I've highlighted in red the things that really have changed. And that's, I think, where the core of what we are going to, you know, are dealing with from a privacy rule perspective on HIPAA. But you can use protected health information with an individual's written authorization. Historically, that had to be study specific. You couldn't have compound authorizations. You couldn't authorize multiple things within a single authorization, and you could not get an authorization for future unspecified research. That's the piece that they've really tried to address in last year's rule. There are other ways you can use protected health information for research. These are largely unchanged. You can get a waiver of authorization from an IRB or a privacy board, and there are standards for how that waiver can be granted. You can use a little more limited set of data by entering into a data use agreement. There are certain purposes for which that may be used, including research. You can use de-identified information, and over the course of this panel, we'll talk more about what that looks like. Not always the data set that you need to do the research you're doing. And there are a couple other things you can do. You can get a certification to do data reviews preparatory to research. You can go in and look at records to sort of set up your research protocol. And there's some other special provisions for decedents' information. So the major changes in the high-tech final rule from last January are regarding the study-specific limitations on future unspecified research and compound authorizations. These are very complex and they're sort of intertwined, and I'll tell you it's really hard to write these forms, having now thinking we had a great win, but we're trying to write these forms to work within these rules. It's not as easy as we had hoped. So the prior position that HHS had taken since the beginning of HIPAA 10, 12 years ago was that research authorizations cannot authorize future unspecified research, and their rationale was that patients aren't reasonably on notice about what that research would be. The privacy rule requires that an authorization describe the purpose of the requested use and disclosure. So when you're getting patients to sign an authorization, typically separate from the informed consent form, doesn't necessarily have to be. It can be integrated, but there are certain statements that have to be in a HIPAA authorization, and one of them is that it has to describe the purpose. And HHS historically interpreted this as requiring a study-specific description. You had to know what study you were signing up for, you were authorizing the use of your protected health information for. And so they didn't allow the authorization for use or disclosure of PHI for future research. So in the high-tech final rule, we have a different approach to this. I think they heard loud and clear, this isn't working. And so what HHS has done is, as of the final rule was published in January, of last year, there's a 60-day sort of implementation period. So as of March 26, 2013, a HIPAA authorization is allowed to permit future research if the authorization adequately describes the future research such that it would be reasonable for an individual to expect that his or her protected health information could be used or disclosed for that purpose. So a big question when you're writing these is how do you do that, right? How do you adequately describe the future research so that it would be reasonable for an individual to expect that their information is going to be used for that research? And sometimes it's not that hard to do. You know, I've worked with entities that are doing study for a particular kind of cancer. They're going to make their best guess that there are going to be some follow-on studies for maybe any other kind of cancer, or maybe, you know, and have been able to sort of write that in a way that they can get comfortable that somebody would know that or reasonably expect that their information might be used for that follow-on study. Certain ongoing studies are grandfathered because who knew, right? And we have all these studies that are already underway. So where where the informed consent and that authorization were mixed together in one form, and the informed consent did describe the future research, then you can those studies basically you can go on and retroactively use this this rule. There's another complication in the HIPAA privacy rules around the rules in terms of what an authorization has to contain. And the privacy rule says that you can't have a compound authorization for uses and disclosures of protected health information that both authorizes research activities for which treatment is conditioned on signing the authorization. Those are conditioned activities. That's, you can't, you know, you're not going to get the treatment unless you enroll in the clinical trial because you're getting clinical trial related treatment. So that's conditioned. You have to sign the authorization in order to be in the clinical trial, which you have to sign the authorization in order to get that treatment. So if you don't get signing the authorization is a condition of getting the treatment. But you can't have that kind of authorization combined with research activities for which treatment's not conditioned on signing the authorization, unconditioned research activities. And I think this is one of the hardest things right now in terms of writing these authorizations, because, you know, a biospecimen bank is unconditioned. You know, it's not, you don't have to sign it to get treatment. And so it's how do you write a compound authorization to do both of those? So historically, what that has meant is that a clinical trial associated with corollary research activities like biospecimen banking, you had to have separate authorizations for the clinical trial participation, because that was conditioned, and participation in the corollary activity, which is unconditioned. So a new approach to that question is how do you write a form to get there? But the final rule from last January does allow compound authorizations for research purposes as long as certain conditions are met. You can tell, the patient can tell, that clearly differentiates between the conditioned and unconditioned research components. And there's a clear opportunity to opt in to the unconditioned component. So it could be a form in which, you know, here's the clinical trial, signing for that, and here's the opt-in, agree to the biospecimen bank. You know, if you're dealing with psychotherapy notes, you can't do this because they're just more protective of that information. And so I think the question is, and that was a carryover slide, so I'm just going to skip through it from a sea change thing, so apologies, Tom. But I think the question is, what does that mean for research? And, you know, certainly it's a really significant change, and it's something that I think has made a big difference in terms of our ability to go forward and create forms that allow future research. But I think it's hard to know how to write those. And certainly this has removed some of the roadblocks to researchers. But I think it's not clear how far it's going to get us. And so in terms of what covered entities are doing now, and I'm working with hospitals, physician offices who are engaged in research, they are trying to revise the templates to permit future research. They're trying to come up with ways of describing that future research that puts patients on notice. They're considering compound authorizations for protocols that involve multiple research activities, investigational treatment, that conditioned component, and then maybe tissue banking. And trying to make those two sets of rules work together, the future research and the compound authorization. They're looking at policies and procedures for how to revoke authorization, because if somebody signed up for two things, and if they've signed up for the clinical trial and the conditioned research, the conditioned part of the authorization, and they've also opted into something else, how are you going to manage it when they want to call and revoke their authorization? Doesn't happen that often, but it can can have important changes for a clinical trial if patients do that. And so you want to really think about your policies and procedures for how they're going to revoke each piece of that, or can they revoke each piece separately, or are they revoking everything all at once? And what does that mean in terms of the integrity of the research that you're conducting? And they're also looking at ongoing studies that involve the possibility of future research to determine if some of those existing studies can be grandfathered under, under that rule that if you already had described the future research in the informed consent, even though you couldn't do it in the HIPAA authorization, but they were all combined together, that you're still good. So I think there are a lot of questions about those forms and where we go from here and what more we really need from HHS, if anything, to kind of continue the process of making this work from a research perspective. I'm going to talk quickly about a couple other issues, Brett, that relate to research and some changes that have happened recently. Brad's going to talk more about de-identification in detail, but want to just highlight for you some of the standards for de-identification, because one of the things you can really do what you want. To Holly's point, from a HIPAA perspective, at least, with respect to de-identified information. And there are two different ways you can get that information. And another change that's happened, and I think why you may, to the extent you're hearing a lot of covered entities question what de-identified information is there have been some changes in the guidance around de-identification in the last couple of years. This is not part of that same rulemaking, but the previous fall, HHS had issued some guidance on de-identification. And I think there's some exciting possibilities here because there have always been the same two standards for de-identification. You can either remove a bunch of data fields, right? You have to take all 18 out. There's a lot of confusion around this. I answered a question last week. No, you can't just take out 17. That's not good enough, right? You have to take out 18 and not know that there's actual knowledge and not have actual knowledge the information could be used to identify someone. And this has been mostly what we've been kind of stuck with under HIPAA because no one knew how to do this, which is the statistician certification. And I think from a big data perspective, there's some real opportunities here. And the reason there are real opportunities is not because the rules have changed, but HHS has finally given us some guidance on what this means. And I think prior to that, guidance about a year and a half ago, covered entities were very nervous about who was a statistician and what did they have to do and how could they, who was qualified enough and how would, how are they going to minimize the risk that they hadn't gotten this right? And because of that guidance, I am seeing a lot of entities really look at big data sets and think about that statistician certification. Pharmaceutical companies coming together to look at data repositories and really using a statistician to figure out maybe it's the date of service that you most need. And how do you get that? And then what else has to be stripped? And really working with the statistician to kind of keep the information that's more important to the research while meeting the de-identification standard there. So I think that's just another important HIPAA change, if you will, but it's really just guidance. The rules aren't different. They finally told us a lot about who those people are, those statisticians, and what they really need to do in a way that I think has opened up some real opportunities. And then last, I just want to talk about the sale of protected health information, because this is another thing that did happen in the high-tech regulations. There is a prohibition now. There always has been, but it's sort of reframed in the rule about selling protected health information. Well, that kind of makes sense, right? But in this rulemaking, there is, and I think it's important for researchers because you have to think about how the money flows and what it means with respect to these rules. Sale of PHI is a new defined term under HIPAA. It means the disclosure of protected health information by a covered entity or a business associate, its vendor, where this covered entity or business associate directly or indirectly receives remuneration from or on behalf of the recipient of the protected health information in exchange for the PHI. So is the covered entity being paid to share data with you? That would be sort of the most basic concept of what a sale of PHI is. Well, maybe, right? I mean, maybe you're paying them to prepare the data and such. So I think you need to be aware of those rules and thinking about HIPAA and research, but know that there are exceptions. And again, I think it's a question of whether the exceptions go far enough to describe all of the things that you do in research. There are exceptions for disclosures for research. It allows a reasonable cost-based fee to cover the cost to prepare and transmit the data. So is that what you're paying? And how do you assess that? They've said that IRBs aren't responsible for that determination. That's really up to it's really going to be up to the covered entity, but something you may hear some resistance from if you're sitting in the research seat and trying to get data from a covered entity to conduct research. There's also some exceptions for public health disclosures. They didn't want to shut down any fees that might be associated with disclosing information to a state health department or other things. They didn't put a limit on it. There's no cost-based restriction, but again, that may sometimes come into play in the research. And then also with respect to grants and contracts and other similar arrangements, there also are some exceptions. Because you can imagine that you get grant funding from the government to do your research, that grant funding requires that you report data, maybe including protected health information, to the government so that you can, give them some benchmarks in terms of where your research is going. That grant money is not, you're not being paid to disclose data, and that's basically the exception they've said. You can get a grant, and you can still provide the reports back to the government to show that you're using the grant in accordance with their requirements without running up against this. And that's obviously important under the Affordable Care Act and all the health reform kind of quality reporting provisions. So that's all I have. It's sort of a high level of a lot of issues coming up in the HIPAA research context, and I'll turn it over to Alice.